for our next sessions. Our next two sessions will be moderated by Dr. J.P. Sahu. Slides, please. Sir is additional professor in the Department of Endocrinology at JIPMER, Puducherry. Sir has several awards to his credit. Sir has won the Professor MMS Ahuja Award for the Best DM Student. He has also got the ASI A.V. Gandhi Award in 2018 for the Best Conclusion for his student dissertation. Sir has also won the JIPMER Scientific Society Award 2019 for the Best Original Paper for the student dissertation. Sir has to his credit 95 publications in PubMed Index journals. I welcome Sir to introduce our speakers for the next talk.
Am I audible? Thank you, Deepika, for kind introduction. Very good evening to all. We have two eminent speakers, Dr. Nitin Kapoor and Dr. Sunil Kota, for our today's debate, that is intermittent fasting versus daily calorie restriction for weight loss. So first of all, I would like to invite Dr. Nitin Kapoor, who is working as an associate professor in Department of Endocrinology, CMC Vellore. He has got many awards and scholarships, and he has published more than 130 research papers in various national and international journals. And he is also editor of the textbook that is a practical guide to diabetes mellitus. Over to Nitin.
Thank you, sir. Yeah, so I'd like to share my screen. Right, so thank you right at the onset. I'd like to thank Dr. Vijay Bhaskar Reddy and the entire organizing team at Pondicherry for inviting me for this talk, as well as for organizing such a splendid event, and that too in a very short period of time, and getting so many international speakers first time in the history of Trendo, which is really the highlight of this meeting. So over the next 10 minutes, I've been given a mandate to speak in favor of intermittent fasting. And I think I'd like to mention in the beginning itself that this is going to be a friendly debate. Dr. Sunil and me are good friends. We have been good friends for almost a decade that we've known each other. Our area of work and interest is also common. We like to work in the field of obesity. And I think we've decided that we, rather than just saying as to which diet is better, we are going to really focus on as to in which patient what diet will work. So we move on from just knowing whether one diet is better than the other, but a more practical and important aspect would be that to choose the right patient for a particular diet. So in the next few minutes, I'll take you through the evidence to support that. The evidence looks same. I'm just going to tweak the way we are going to put it forward. So like many other age-old traditions, especially Indian traditions, be it yoga, be it drinking in copper vessels, now these traditions are coming back. And one such tradition is also intermittent fasting, which was there many years ago in the Indian history, and still is there and is making a big comeback, unfortunately, more recently, first in the Western world and then emulated even in India. And as in the name is intermittent fasting, we mean that there are periods of fasting and periods of feeding which may differ. It may differ in terms of hours. In 24 hours, it may be divided as 16:8 or sometimes 18:6. Sometimes it may be divided on basis of number of days in a week, like 5:2, or sometimes it could be alternate day fasting. But by and large, when we have a patient in the clinic in front of us, and we have to decide which diet we have to prescribe for our given patient, there are a couple of things that we should look into. The first point and the most important point, I would say, is whatever diet we prescribe, we are prescribing that diet to achieve weight loss, which is not a short-term goal. As of today, we know that obesity is a chronic disease, and our patients should be able to follow this diet long-term. So the first thing is whether the acceptability and long-term sustainability of this diet will be there in our patient or not. And I'll present the evidence in favor of intermittent fasting here. We'll look at as to what the patient wants. Now, there will be sometimes patients, doctor, I want to lose weight because I have an excuse like maybe my sister's wedding in 6 months and I want to lose weight for that. On the other hand, there might be patients who are pre-diabetic. They are concerned that they have got such young onset diabetes that may happen, and they want to lose fat, or they want to get the metabolic benefits of weight loss. So that also needs to be taken into consideration. As physicians, yes, we are always worried about cardiometabolic benefits and whether the diet is going to work in that aspect, and we look into the evidence for that. And before I conclude, I think the most important thing is when we look at so much literature that is available, we need to customize that for the Indian setting, and what really works in our country is what we have to see. So I'll present to you the evidence for these different domains, and let's look at the acceptability and long-term sustainability. And just before that, I think this is indeed a very important topic because yes, obesity is a big problem in India across children, across elderly, and even in two-tier cities like Vellore. And in this particular paper with both Dr. Sunil and myself, we have co-authored. And what we really want to put across is that the way forward for good obesity management is a patient-centric approach. We don't say that this diet is better than that diet. We bring the patient in the center and whether this particular patient will benefit from something or not. And the main aim is that we want to achieve long-term sustainable goals, and we don't want to have weight cycling or what is known as a yo-yo phenomenon. And this is a patient that I had seen a couple of days ago, a medical professional who's now a consultant. And this is what is a classical yo-yo phenomenon with weight increases, then comes down, increases, come down. And this is something that is not good. It is proven not to be good at the cardiovascular level because of the changes and the fluctuations. There are autonomic changes that happen. There are metabolic changes that happen, and they all are definitely not good for the patient. So when we talk of intermittent fasting, and then we look at the acceptability or sustainability, and in this study, this is a thematic analysis of patients who had intermittent fasting. What people say is that definitely this is less cognitively demanding, easier to understand, easier to follow. So by and large, this kind of a diet is good for somebody who is not going to be able to spend a lot of time understanding different technicalities of diet, the macronutrients, the protein-carb ratio, the calories. So it may be easier to adapt for a person who has less time to spend and maybe less cognitive thinking that one requires. So in this particular study, many participants did find intermittent fasting preferable as compared to previous experiences of continuous fasting. So maybe intermittent fasting is something good for people who are not willing to invest a lot of cognition in deciding their diets. This is really important because it does impact quality of life. And in the study, what we found was that the comfort with eating and the experience with dieting is really, really important. And it has an impact across different quartiles of BMI. Whether the patient wants fat loss and weight loss, and what really did put intermittent fasting in bad light for many years was this paper, which was published in 2014, which looked at 19 studies comparing intermittent fasting versus daily calorie restriction. And what it said was that for weight loss, it is the calorie restriction which is superior. Intermittent fasting is not so good for weight, but when we read in between lines, it is the visceral fat mass which reduces remarkably when we have intermittent fasting as well as calorie restriction. So if somebody is looking for good weight loss, then as per this analysis, it was shown that it is not good. But that's not really something that we are really looking for as physicians. We know, especially in the Indian phenotype, where it's not the weight that we are worried about, not the BMI that we are worried about. There are a lot of people with normal BMI, high fat that we see. But then it was this analysis which was published last year in Nutrients, which again looked at another 20 studies. And what it found was that 9 out of 11 studies actually didn't show much difference in weight loss as well as fat loss. So both diets performed well, though overall evidence for fat loss is similar in both the groups. What about cardiometabolic benefits? Yes, intermittent fasting is good. This is a study from Turkey. Just as short as 12 weeks, there are remarkable improvements in different cardiometabolic parameters. So it does work. It works a little better in people where we want to prevent diabetes. So calorie restriction did not show much evidence in people who are pre-diabetic and looking for prevention of diabetes. So intermittent fasting again better here. And in people with diabetes, there was no difference between intermittent fasting versus calorie restriction. So there is a place of intermittent fasting in people who are pre-diabetic who want to avoid getting diabetes or preventing diabetes. And this paper in JCM last month talks about the importance of intermittent fasting both for lipid metabolism markers in the skeletal muscle as well as in the blood. What really works in the Indian setting, and this is again data from our center, the Westday Clinic here, and what we found was there are two types of phenotypes when we look at patients. When patients come in with obesity in our clinic, there are patients who have a lot of binge eating. On the other hand, there are patients who eat little food, but all throughout the day, and they're called as grazers. We find that in our Indian phenotype, grazers are more common than binge eaters. And grazers, because they eat all throughout the day, probably intermittent fasting is better off for them. So overall, to sum up, what we need to do is a patient care approach. And when we have a particular patient in front of us and we have to decide whether it's intermittent fasting or not for that patient, we are going to look at the pair of phenotype of that patient. Yes, if the patient is wants to prevent diabetes, I would prefer intermittent fasting. Obviously, if the patient has established diabetes on sulfonylureas, on insulin, I wouldn't like to give intermittent fasting there. Somebody who has access to food all the time, somebody like a housewife, or in the first paper, as I showed, that intermittent fasting is less cognitively demanding. So again, it would be better to use it there. It would be better to use it in somebody who's not a binge eater, but rather a grazer. So overall, they're different. It's important not to decide which diet is better. It's important to decide for a particular patient what is better. So to sum it all up, yes, there are different types of diets. We have to look at the acceptability and sustainability, which probably is less cognitively demanding for intermittent fasting. There's good evidence for fat loss and also now similar and comparable evidence for weight loss. Intermittent fasting is shown to be good for cardiometabolic risk prevention, specifically for diabetes prevention, but equally good for people who have established diabetes. And looking at the phenotype of the patient, how he eats, whether it's a grazer or binge eater, better for grazer, less better for binge eaters. Overall, it's a patient-centric approach. We put the patient in the center. We do not say which diet is better, but we find out what works good for a particular patient. I'd like to thank here and over to Dr. Sunil. Over to Dr. Sahab.
Thank you, Dr. Nitin, for a nice presentation. I will come back to you after Sunil's talk. Now I invite Dr. Sunil for talking on daily caloric restriction in weight loss. Dr. Sunil Kumarkota is working as consultant endocrinologist at Diabetes and Endocrine Clinic at Barampur, Odisha. He has more than 80 peer-reviewed publications and 18 book chapters. He has got many awards and scholarships. Recently, he has got RSSDI award for best innovation in diabetes care during challenging situations in 2020. And his poster on ileal interposition with sleeve gastrectomy for treatment of type 2 diabetes has got the best poster award in AAC 2012 USA. He is also a member of various national or international endocrine societies. Over to Sunil.
Is it visible now to everyone?
Yes, sir, it's visible.
And I'm audible as well. Okay. So thank you so much, JP Bhai and Sadish sir, for inviting me, and very good evening, respected everyone. I am just trying to add some funny question to my presentation, and because we are on the same page, as we have also published one paper on the secure model. So after that insightful presentation on intermittent fasting, I'm going to vouch for daily calorie restriction. So first of all, hearty congratulations to my dear friend Nitin, because he has had his PhD thesis submitted on 3rd December, just 2 days back, with the University of Melbourne. So big kudos to him. So he's just a master on obesity. And before I started preparing for the topic, I just wanted to know what calories are. These are tiny creatures that live in your closet and sew your clothes a little bit tighter every night. So why not restrict them? And I'm not going to indulge into any sort of debate on diet with my friend of last over a decade. In fact, we have already told you that via Nitin that we are not going to fight with each other. Rather, we are on the same side of science. Hum science ke taraf se hain. But again, to start with, looking at this picture, I would always believe that a small amount of rain a day would always be better than very huge amount of rain that would be disastrous. So with this brief preamble, I'm going to start off with my topic proper. First of all, I'm going to tell you some of the aspects of daily calorie restriction in weight loss. It is about consistent reduction on daily calorie consumption without reaching a state of malnutrition, and that ensures adequate intake of protein and essential micronutrients. It avoids cravings, snacking, and it also helps sticking to the diet. This is a seminal study of 6 months, 2006 JAMA, 48 patients divided into 4 groups, control calorie restriction alone or with exercise, and another one was the very low calorie diet. And calorie restriction was actually instrumental in reducing weight over the period of 6 months, and very low calorie diet gave rise to maximum of weight loss. And apart from that, 2 biomarkers of longevity, those are the fasting insulin level and the body temperature, were also reduced by prolonged calorie restriction. This is the Calorie 2 study, which was looking at a 2-year effect of the continuous energy restriction on body composition changes. What you can see is that the fat mass is getting lost, fat-free mass is getting higher, more so in males, probably attributed to higher fat-free mass at the baseline. And what about some other associated benefits? You can see we are talking about a number of cardiometabolic risks, and it is getting actually benefited in continuous energy restriction thanks to the alteration in postprandial glucose lipid metabolism, and this is actually intact with the continuous energy restriction. And we are talking about the diabetes remission direct trial, which was giving us a result of 46% diabetes remission in the people who are having a continuous daily restriction of calorie to the tune of 825 to 853 kilocalorie per day. And this is a recent one in ADA 2019 preview trial. It is a study of over for 3 years, and the weight loss is proportional to the intake of protein and the intensity of exercise that is being done. At the bottom, you can see there is a 96% diabetes prevention with diet and exercise management, that is continuous daily calorie restriction. A number of mechanisms are put forward to cite a few, like adiponectin, activation of AMPK, reduction of oxidative markers, and leptin. And what about some other parameters? Like it states that the calorie restriction gives rise to downregulation of insulin IGF pathway, which is associated with increase in longevity in the skeletal muscles, and the transcription profile also changes to resemble those of younger individuals. So now let us talk about the intermittent fasting. Are we clear to begin with? Again, on a funny note, my friend Nitin is known to take risk on his stride. But again, here there is a lack of standardization of terminology to describe different strategies. There are alternative fasting, there are time-restricted feeding, there are periodic prolonged fasting. And again, if you talk about consistency and adherence in chronic disorders, it is only 50%. And if I were to pick among one of these 2 options, probably I would pick a daily pill over a twice a week or an injection or a pill. And apart from that, most of these strategies work on ultimate calorie deficit, but that may be undone on a non-fast day because of the splurge that the patient can actually face. And now let's look at the weight loss, which happens to be the main topic for today. And this is the study in 2018. I'm just going to take you through. It is a 50-week study. At the end of 12 weeks, numerically more weight reduction was found with intermittent fasting, which was not significant. At week 24 and week 50, there was near similar weight loss in both the groups. But there is a catch to this, that there is a slight trend for weight regain between 24 24 to 50 weeks, especially the intermittent calorie restriction group. And apart from that, there are some troublesome factors associated, like during the energy restricted days, you start to feel cold, there is tiredness, lack of concentration, and non-energy restricted days, there are chances of dizziness and cramps in the leg, which can sometimes be troublesome. And what biggest thing, the biggest takeaway point from this would be the compliance would be a paltry 20% at the end of 50 week. And the reasons are known because of the possible side effects. This study again in JAMA 2017, 100 patients studied over a period of 4 years. Look at the first sentence. What it says is that participants in the alternate day fasting group ate more than prescribed on fast days. Prescribed on they were actually meeting the prescribed energy goals. So taking more on fast days and taking less on feast days, are we not following the daily calorie restriction mode? But the mean weight loss was similar, and the patients on very low calorie diet group had a reduced level of the hunger increasing hormone, that is the ghrelin. And it is associated with only short-term weight loss of up to 12 weeks. But again, weight regain can happen between 24 to 50 weeks, and other cardiometabolic parameters, they didn't differ much. And again, this is a study in Nutrients 2019. Again, Nitin has already highlighted it. 9 out of 11 studies having duration between 8 to 52 weeks, there was no change in weight or body fat loss. This again is a study, Obesity Science Practices in 2016. In terms of fat loss, again, as Nitin has stated, this alternate day fasting is better, but in terms of weight loss, the VLCD is better. But again, we need to look at what other evidences are there in favor of intermittent calorie restriction. The predominant drawback is that most of these studies are short-term. We need studies beyond 12 months or so. And apart from that, most of these studies have put both the strategies at same pedestal in terms of the cardiometabolic alterations. And the average dropout was again a 31% in the alternate day fasting strategy. So this study basically tells us that the intermittent fasting can be assumed as a weight loss program, but can be thought of as a detoxification or a regeneration or a longevity extending process. It cannot be assumed as a weight loss program. And again, this study in 2018, it tells us that the weight loss was not difference between alternate day fasting and the daily calorie restriction. But again, the dropout rate was significantly higher in the ADF. But again, in terms of the fat-free mass and other parameters, both of them are very similar. This study probably tells us that only alternate day fasting is not going to be of benefit. It has to be combined with exercise to give rise to meaningful weight loss, reduction in LDL, and increase in HDL. And now let us look at some of the other benefits which are being claimed by the intermittent fasting. Look at the glycemic profile. Some of these studies are saying non-significant, some of these studies are showing reduction. So there is an equivocal response. So is the case with lipid profile. Some studies have gone on to say that there is an increase in total cholesterol and LDL cholesterol with intermittent fasting. Similar is the case with the inflammatory markers. Most of these studies have shown non-significant changes, but some of them have gone on to show reduction in inflammatory parameters. And this study has shown us that the oxidative markers, the anti-inflammatory markers are actually getting adversely affected with 32 weeks of alternate day fasting. And its impact on athletic performance, because some of the people would like to lose fat, but if the results have not been uniform. So we have to be very careful when we try to prescribe this, because its effect on muscle strength and anaerobic capacity was non-significant. And some sort of the intermittent fasting can give rise to impairment in aerobic capacity. Some can be effective for improving it. There is no generalization applied to it. And in terms of the menstrual cycle, it is stated, some of the studies have stated that there is a longer average menstrual cycle and there is a reduction in mid-follicular phase of luteinizing hormone. There can be fertility affected negatively, but these are some of the evidences from the humans and animals. And during these COVID times, the extreme diets like the ketogenic diets and the intermittent fasting have to be avoided, for they can give rise to deficiency in macro and micronutrients. So what exactly are the takeaway points from some of the leading reviews that we need to know? That it clearly tells us that this is for short-term weight loss, But for long-term maintenance, you need to go for low-calorie diet or addition of physical activity. With regards to consistency, tolerability, and safety of alternate day fasting, we do not have much data. And again, dropout rate is very high because of the several of the side effects, and it cannot be used in type 1 diabetes, pregnant and breastfeeding women, elderly individuals with eating disorders, and those in need of regular food intake. So we have a lot of evidences in support of in the intermittent fasting, but do we have this evidence that we need? Because sustenance is an issue. No robust research for healthcare professional to recommend it as a standard practice. And again, we do not know which type of intermittent fasting would be best and which type suits whom. And again, it is stated, as Nitin has stated, for weight loss, you have to go for calorie restriction. For fat loss, you have to go for intermittent fasting. And the NEJM states that one who is ingrained in our culture to have 3 or 4 times meals a day, it is very difficult to restrict food to have less compliance at the end of the period. And we have number of side effects which can actually hamper our compliance to the issue. And again, the most physicians are not trained to prescribe specific intermittent fasting interventions. So the limitations of studies on intermittent fasting, low number of study subjects, no physical activity measurement is not that impressive. The consistency, tolerability, and safety is yet to be established, and variable results on associated benefits. So the daily calorie restriction, weight loss and weight maintenance is good, and it improves the risk factors of cardiometabolic disorders. It slows aging, increases average and maximal lifespan. So again, on a funny note, in evidences against, if my partner, my dear friend Nitin, sticks to intermittent fasting, probably the audience are not going to accept. Some can claim themselves to be the dawn, alternate day fasting, the time restricted feeding, but again, the daily calorie restriction is above of all them. We both have deliberately chosen to project because this is the message to go. One who needs fat loss needs to go for intermittent fasting. For weight loss, the daily calorie restriction is the one. And again, patients have renal and hepatic disorder where hepatic glycogen store is not there. You have to probably have to go for daily calorie restriction. Established diabetes, hypoglycemia, pregnancy, breastfeeding, one who is executive, one who is working, who doesn't have access to food very often, one who is a binge eater, and one who likes social life, probably the daily calorie restriction is the way to go. Thank you all for the patient listening. Now it's over to Chairperson.
Thank you, Sunil, for highlighting the importance of daily calorie restriction in weight loss. Nitin, would you like to add a few things?
Maybe just 2 small points. As we see, the evidence is everywhere, all over the place. There is no concrete evidence to say one is better than the other. And as Dr. Sheshadri has always taught us, in science, we have to ask the right question to get the right answer. And I think the right question here is not which diet is better, but to put the patient in the center and see that what will work for this patient. And that's what Sunil and I together have thought and told, that you have to look at the barophenotype of the patient. You have to look at the metabolic aspect, the social aspect, the dietary aspect, the psychological aspect of the patient, and then decide which diet you have to actually provide. And all diets are good. Basically, all of them are act with calorie restriction. It's just a method of restricting calorie which is better suited to a particular patient. Thank you.
Thank you. Sunil?
Yeah, actually, I am going to reiterate what Nitin has just said just now, because that's what we have tried to put it across in our paper on that secure model. And again, the same thing, that it all depends on the comorbid phenotype, metabolic, lifestyle and social phenotype, dietary phenotype, and which particular pattern suits the patient the best, and one which can be followed over a long period of time. That's what should be picked up.
Right. Nitin, one question is there in chat box for you. Can you tell in brief regarding paleo diet?
Right. So personally speaking, in my practice, I do not recommend paleo diet or keto diet unless the patient is willing to do it long term. In India or in our culture, food eating is a very cultural habit. So if somebody is eating a little different diet, it may work for 6 weeks, may work for 3 months. It does affect in weight loss, there's evidence to show. But long-term sustenance, when we have to talk about, then these keto and paleo diets in the Indian setting will not work. When I was observing in US, there they are able to give meal replacements 4 times a day. People come back after 6 months having lost 30 odd kgs. But in India, if a housewife is not going to eat all the meals all throughout the day, that will not work more than 3 to 6 months. So personally, I'm not a big fan of these fancy diets. Whatever works on long term with sustenance is the way forward.
Thank you, Nitin. So the message is it is not intermittent fasting, or it is not daily calorie restriction, which is better and which is bad. Basically, it's the patient-related factors that will decide which approach will be the ideal approach for losing weight for that patient. Thank you, Nitin. Thank you, Sunil. Both the speakers have done excellent job. Thank you. So now we'll move on to the next session. Uh, so next session, the topic is spontaneous hypoglycemia in adults. It's a great pleasure for me to introduce Dr. S. Ramkumar to give talk on this topic. He is currently working as an assistant professor in Madras Medical College and is also attached to Apollo Main Clinic in Chennai. He has done his DM endocrinologist training from AIMS New Delhi, and after that he has got clinical fellowship in diabetes from Auckland, New Zealand. He has various achievements like A.V. Gandhi Award for Excellence in Endocrinology in 2014. He has also got ISPAD Award, and he has many publications to his credit. Over to Dr. Ram. Time.
Sir, can you see the slides now?
Yes, sir, we can see it.
Yes, sir. First of all, thank you very much, sir, for giving this opportunity to talk on this Trendo. Maybe this is the first talk in last 7 years being in Tamil Nadu. So I thank the JIPMER team, Dr. Satish sir and Dr. Vijay Bhaskar Reddy sir for giving this opportunity to talk on this topic. Can you hear it, sir? Okay, so today I'll be talking the next 30 minutes on approach to hypoglycemia in adults. Okay, yeah. So before this, I'll just go with a case scenario. This is a 14-year-old boy who with the type 1 diabetes who was detected to have diabetes a year back, and this boy was brought by his mother with complaints of recurrent hypoglycemia, low sugars for the last 1 month. His last HbA1c was 7.6, so which shows he was definitely hyperglycemic. Sorry. Definitely hyperglycemic, and the parents have stopped the insulin last 1 week, but he continued to have persistent low blood sugars. So this was the initial reports of sugar and other parameters. If you can see, the blood sugar was 43 and urine glucose was 2+. So he was definitely hyperglycemic before this hypoglycemic episode. And you can look at the cortisol levels here. It was 24.8, and his ACTH was also high. So this is what normally happens whenever somebody goes for hypoglycemia. The counter-regulatory hormones, cortisol, come into play and try to push the blood sugar up. And if you see the insulin and C-peptide, this is a normal response. This cortisol response is a normal response. This insulin is high and the C-peptide is low. So this clearly points that C-peptide being low clearly points that the body is not producing insulin, and this insulin which is high is actually an exogenous insulin. So this is a clear-cut case of a factitious hypoglycemia, which was later checked with the boy, and he used to take in the middle of the night insulins due to some psychological issues. So when do you work up for a hypoglycemia in a non-diabetic? So we work up for hypoglycemia when we fulfill all these 3 criteria. One, there should be symptoms which is consistent with hypoglycemia, low plasma glucose concentration, relief of the symptoms after the plasma sugar concentrations were normalized by treatment. So these are some of the basics you need to know when approaching a case of hypoglycemia. We need to know all the different causes of hypoglycemia and whether the patient is a diabetic or a non-diabetic, and whether it's a fasting hypoglycemia or is it a postprandial hypoglycemia, and what are the levels of insulin and C-peptide, whether it's a high insulin or a low insulin condition, whether the ketones are produced or ketones are absent, and interpret how the other lab reports. So these are the different causes of hypoglycemia in adults. You can classify as fasting or postprandial. This is the latest classification, like classifying them as sick adult and well adult. These are the different causes of hypoglycemia in a sick adult. Like among them, the most common cause of hypoglycemia are drugs, insulin, sulfonylureas, alcohol, and there are other causes of includes any systemic disorders, especially the critical illness, liver failure, renal failure, sepsis, and the two important hormones are very important. One is the cortisol deficiency, another is growth hormone deficiency, and non-islet cell tumors. These are also very rare causes of hypoglycemia in adults. And in a normal well adult, these are the causes. Among them, the most important thing is the accidental or factitious hypoglycemia. The endogenous hyperinsulin causes or reactive hypoglycemia, insulinoma, residuoblastosis, and autoimmune conditions. Among the autoimmune hypoglycemia, we have antibodies to insulin and antibodies to insulin receptor. In children, we don't have this non-islet cell tumor. Instead, we have the large group of inborn errors of metabolism. When we say about the lab reports, these are the common tests we do, like insulin, C-peptide, and proinsulin. This proinsulin is actually contains the insulin, which contains the A chain and the B chain linked by the connecting peptide called the C-peptide. So this proinsulin, when it's cleaved, it produces both the C-peptide and the insulin. So whenever the insulin is released into the portal vein, it is secreted in equimolar ratios. So it is secreted in the ratio of 1:1. And this is very important because when the insulin reaches the liver, there is an enzyme called insulinase which degrades the insulin. So whichever insulin that comes out into the peripheral circulation is actually less than what is there in the portal circulation. But the C-peptide levels are almost same. So whenever we measure the insulin C-peptide ratio in the portal circulation, it will be 1:1. But in the peripheral circulation, it will always be less than 1. And there are only two conditions which can have a high insulin and C-peptide ratio. One is an autoimmune hypoglycemia, and second is the exogenous insulin, as we had seen in the previous case of a type 1 diabetic child with factitious hypoglycemia. So so whenever the blood sugar goes low, the counter-regulatory hormones come into picture. So the glycogen undergoes glycogenolysis, and amino acids and glycerol undergo gluconeogenesis, and subsequently on prolonged fasting, the fats undergo lipolysis. Fatty acids are produced which enter the liver, and the mitochondria get converted into ketones. Ketones are the major source of fuel for the brain. These are the places where insulin can inhibit. They can inhibit gluconeogenesis, they can inhibit glycogenolysis, and they can also inhibit lipolysis. These are the counter-regulatory hormones, growth hormone, cortisol, epinephrine, and glucagon. As I mentioned earlier, two hormonal deficiencies, especially growth hormone deficiency and cortisol deficiency, can cause hypoglycemia. So whenever the sugar goes low at around 80 milligrams, the first thing to be recorded is the reduction or the suppression of the insulin secretion. Subsequently, epinephrine and glucagon are produced in excess, and the cortisol and growth hormone response happens at 60 milligrams. So, and the patient develops a sympathetic symptoms, that is adrenergic symptoms due to this epinephrine, and further reduction in blood sugar levels can cause neuroglycopenic symptoms. This is just to show an example of how the body reacts to hypoglycemia. Actually, this was recorded where the blood glucose value was 35. You can see the cortisol level was 29, insulin was 0.5, and growth hormone is 51. So actually, the actual diagnosis was an underlying inborn error of metabolism, but you can just see the response to hypoglycemia by the counter-regulatory hormones and the suppression of insulin. So whenever there is hypoglycemia, but the insulin insulin gets suppressed. So there is an activation of lipolysis. The fats undergo lipolysis and produce fatty acids. This enters the liver, gets converted into ketones. So the significance of ketones is a major source of fuel for the brain during hypoglycemia and for the energy production. So whenever there is ketosis, actually you don't have to worry about that. But if there is a non-ketotic hypoglycemia, this is actually more dangerous. This is actually more dangerous than a ketotic hypoglycemia. So so how do you approach based on the insulin and C-peptide levels? If you have a high insulin and high C-peptide during hypoglycemia, then it indicates it could be endogenous. So it could be insulinoma or endogenous secretion of insulin from the pancreas, or autoimmune or insulin secretagogues. If the insulin is high but the C-peptide is low, as in our first case, it is a case of exogenous insulin. If both are suppressed, then it could be due to other reasons like hormonal deficiencies like cortisol, growth hormone, critical illness, chronic renal failure, liver failure, sepsis, inborn errors of metabolism, or non-islet cell tumors. So these are the highlighted ones, or the test usually we do for the evaluation of hypoglycemia in adults: glucose, the insulin, C-peptide, beta hydroxybutyrate, that is the butyrate. The ketones are now being available in many labs. You will also have a ketone meter, or if you don't have, you can do the urine ketones. And serum cortisol and growth hormone are the two hormones normally we measure at the time of hyperglycemia. Based on the initial test, we can subsequently do the sulfonylurea screen, insulin autoantibodies, and any imaging modalities or any gallium doTERNOX like functional imaging, or to localize insulinoma, we may need a calcium stimulated arterial venous sampling. These are the tests that we do it in children. There is a slightly different. Among them, the most important thing that we need to exclude are inborn errors of metabolism. So coming to the case 2, this is a 75-year-old male who had a recurrent hypoglycemia for 5 years duration. So one of the important thing is to look at the patient's history is the duration of hypoglycemia. Also, here he has a chronic duration of almost 5 years, and you look at whether it is a fasting or it's a postprandial. See, he doesn't have any fasting early morning hypoglycemia, but he usually has before lunch and in the evening time. And he was documented to have high insulin and high C-peptide. His MRI pancreas was normal, and there was no GI surgery before. So this was the extended GTT done. His fasting glucose was 115. So definitely he has impaired fasting glucose with a high insulin, suggesting insulin resistance, and a 2-hour value was high with a drop at 4-hour value. So this you can look at the insulin and C-peptide levels. Normally we take more than 3 or C-peptide more than 6, 0.6 as suggestive of high insulin production or endogenous hyperinsulinemic hypoglycemia. So this clearly shows it is a case of endogenous hyperinsulinemic hypoglycemia, and it's a case of a reactive hypoglycemia. So in case 3, she's a 44-year-old female. She also had long duration of illness, recurrent hypoglycemia. But if you look at her symptoms are predominantly in the early morning. But she manifested like forgetfulness, altered behavior, headache, palpitation, sweating, giddiness. This is how an insulinoma patient usually will present. They don't present with characteristic adrenergic symptoms, but they may present with neuroglycopenic symptoms because of long-standing duration. And most of these symptoms often improve spontaneously or after eating in 15 minutes. She had been consulting on many physicians, neurologists, psychiatrists with the various diagnoses of pseudo seizure, panic attacks, or conversion disorder. These are the critical samples. At the time of hyperglycemia, the insulin was 134 and C-peptide was also elevated, suggesting an endogenous hyperinsulinemic hyperglycemia. So this is looking like a case of insulinoma. So we did the imaging for insulinoma. Normally we do the CT, MRI, endoscopic ultrasound, or a functional imaging. But surprisingly, there was no pancreatic lesion, but a large renal lesion was identified. These are the sensitivity of all these imaging modalities. So many times we may need to do 2 or 3 imaging modalities if you are not able to identify the lesion in the pancreas. And this was a CT abdomen which showed a large lesion in the kidney, and the gallium-Dottnok, which is done to look for any somatostatin receptor, presence of somatostatin receptors, showed the uptake in the same mass lesion. So after surgery, we did the histopathology and we did the staining for the neuroendocrine markers. Chromogranin and cermatophysin were positive, and we wanted to stain for the presence of insulin, which was positive as expected. The insulin stain was positive. This was the electron microscopy showing the neurosecretory neuroendocrine granules here. This is on a magnified view. So it's a case of actually a case of a neuroendocrine tumor can be as an ectopic insulinoma. So this is the case, which same case which was published. So coming to the case number 4, he was actually related to the medical field because he was a distributor of surgical equipments. He was referred by a surgical gastro. He was having recurrent hypoglycemia, but it was for a short duration, maybe I think maybe less than 2 months duration. And he has multiple documented readings of 50 to 60. He has erratic values like both fasting as well as postprandial, and but he used to eat multiple times. He started eating every 2 hours, so you cannot clearly say whether it is a fasting or a postprandial hypoglycemia. And he had gained some weight after in a 2 months period. He was not diabetic. He was actually diagnosed to have some dyslipidemia and was prescribed tonaclopidem, and he took for 10 days only and then stopped that. And initial evaluation was showing a very high levels of insulin, more than 1000. MRI pancreas was normal, and he was also diabetic, detected to have diabetes. This was extended GTT done, although the fasting was 61. As I said earlier, he was actually fasting when this test was done because he was forced to eat at multiple times. There was a drop, but there's a tendency towards hypoglycemia, but there's no documented after the postprandial period. I mean, post glucose test. So, and we did a 72-hour fasting, and surprisingly, we didn't document any hypoglycemia, but the ketosis were documented. Serum ketones were started increasing. So, with the background history of high levels of documented insulin, we thought in terms of autoimmune hyperglycemia. So we did the anti-insulin antibody, which came out to be significantly positive. So this is a case of insulin autoimmune syndrome. There are 2 types. One is the anti-insulin antibody mediated, and one is the anti-insulin receptor mediated. This anti-insulin antibody mediated, the main pathogenesis is the binding of the insulin with the insulin anti-insulin antibody and then subsequent release. So what happens is after the patient takes a meal, the sugars, there is a rise in blood sugar followed by a dip in blood sugar. The rise in blood sugar is actually because of the insulin binding with the insulin antibody. Subsequently, there is a dissociation of this insulin from the antibody, so the causing very high levels of insulin, causing a postprandial hypoglycemia. Anti-insulin receptor mediated is quite rare. Here, the anti-insulin receptor antibody binds as a partial agonist, and it causes both fasting and postprandial hypoglycemia. This is one of the rare conditions. This was described in Japan, and there it was reported to be the 3rd leading cause of spontaneous hypoglycemia after insulinoma and extrapancreatic neoplasms. This is an autoimmune condition, so we can expect other autoimmune conditions to coexist. Most of these, most common reason is the exposure to a drug. So it is important that we need to ask a proper history, especially if such a recent onset of significant recurrent hypoglycemia is there. 50% will have a exposure to sulfonyl group, and the characteristic finding is the presence of insulin more than 1000. So these are the different drugs that are implicated in insulin autoimmune syndrome. I think these drugs should be inquired in the previous prescriptions. Of this, methimazole is the most common, and a recent report suggests alpha lipoic acid also to cause autoimmune hyperglycemia, which is widely prescribed for most diabetics. And these are the drugs which he was taking before developing the hyperglycemia. And although clopidogrel does not have a thiol group, inside the body it gets converted to an active metabolite which contains a thiol derivative, and it is known to cause autoimmune hyperglycemia, and has been reported in few studies. Even this year also there was a publication in JCM. So the management is primarily discontinuing the drug and small, frequent, low carbohydrate diet. The management somewhat overlaps with the reactive hypoglycemia. Usually the autoimmune hyperglycemia settles in 3 to 6 months. These are the drugs that are recommended. Actually, there is no documented, lack of trial-based evidence because of this rarity of this condition. Since he was in the medical field, he preferred to continue only with a small, frequent, low carbohydrate diet and acarbose. And he actually had within one to 3 months, there was the anti-insulin antibody starts declining, and it was completely undetectable over a period of 3 to 6 months. This is a patient who was a 75-year-old male. Unlike the other case, he presented with a first episode. There was no previous episodes of hypoglycemia, and he presented with a severe hypoglycemic seizure requiring admission in the neurology department. Our opinion was sought after a day, and this was the blood sugar levels. So at the time of hyperglycemia, insulin was 143 and CPAP 28, and ketones were negative. So clearly it's a case of endogenous hyperinsulinemic hypoglycemia. So since it was the first episode of hypoglycemia, so as I said earlier, insulinoma, there would be a previous history symptoms suggestive of a fasting hyperglycemia. This was the first episode. So the first diagnosis was accidental exposure to sulfonylurea. When we inquired, his wife was he's a 75-year-old male, and his wife was diabetic. He was not diabetic, but his wife was diabetic, and she was taking glycoside. So in the neurology department, he was treated for the IV dextrose. A CT abdomen was done, and endoscopic ultrasound was advised initially. But by the time hypoglycemia normalized, so if hypoglycemia is, it's very rare to get a hypoglycemia which is normalized in insulinoma. So the possibility was somehow that his wife's medicines might have been wrongly prescribed. Although we inquired about who is giving the drugs, his son denied the fact that the drugs were given by him only, and he was clearly doing it without any mistakes. So we discharged, and then we thought if hypoglycemia recurs, then we can consider working up for insulinoma later or other causes. But again, 3 weeks later, he presented with one more episode of severe hypoglycemia. So we admitted under our department, and we took samples for his serum and urine and sent it for a sulfonyl screen. And this was the report. So glycoside was tested positive, and the wife was actually taking glycoside. This was positive with the urine sample. So this was a case of a sulfonylurea induced hypoglycemia, but this did not look accidental, but was intentional. So, and coming to another case, this is a 35-year-old male who is a diabetic. Unlike the previous cases, he was a diabetic since 17 years of age, and he was having recurrent hypoglycemic episodes 1 year, and this was initial blood sugar 300, HbA1c 18.6, but there's no decay. He started on insulin. Almost for another 17 years, he was 34 when he came, and his sugars were never under control. And he also had very erratic. There is no time. We cannot say it's clearly fasting or postprandial hypoglycemia. Recurrent multiple episodes and increasing episodes, multiple admissions. Nowhere they were able to identify any lesion. And he, despite discontinuing insulin, he was having recurrent hypoglycemia. There is one significant history that he was having an addiction to propoxyphene. He was obese with the CKD and HbA1c of 6.7. His MRI pancreas was normal. These are the blood sugar values. You can see the insulin levels 171 and 260, and C-peptide levels were also, except for one value, other values are elevated. So as I said, more than 0.6 indicates endogenous hyperinsulinemic hypoglycemia. But if you look at the insulin levels, there were 171 and 260. So this was the literature. In insulinoma, the serum insulin levels, unlike what we expect, the levels usually don't go much higher. So usually the levels are much lower actually during the episodes of hyperglycemia. In one series from AIMS, the mean serum insulin level was 44, and the maximum level they reported was 138. In this patient, you can see levels was 171, 260 and all. This was a CT abdomen, Dotenok, everything did not show any pancreatic lesion. So we thought maybe we are missing something, and we did an insulin C-peptide ratio. As I said, the insulin C-peptide ratio, even in insulinoma, it should be less than 1. Here, strangely, it was more than 1. So definitely it narrows down to only 2 possibilities. So either it is autoimmune or it is factitious, exogenous insulin. So, but he completely denied despite staying in a hospital, and we are not able to clearly pinpoint and any exposure. Although there were some subtle clues, like one time he was found to have insulin in his hand. Um, Subsequently, we started examining him fully. Once this report came, then we were very confident that there is only one possibility, which is exogenous. These are some of the clues I think we should remember whenever considering the possibility of factitious, because we can confirm factitious only if we have a high insulin and low C-peptide, but the patient should accept that, or there should be a CCTV evidence. Here, he was a known diabetic. This is very, very common. Most of these factitious hypoglycemia or already diabetic or healthcare workers who have access to these insulin, like in the previous case, the father giving the medicines. The wife was diabetic. He was propoxyphene addiction, high insulin C-peptide ratio, the absence of autoimmune hyperglycemia, and subsequently there were some needle marks, and these are other clues which we thought, but he never agreed that he took insulin. Subsequently, he was referred to a psychiatrist, and I think weeks later, he agreed that he was taking insulin inside the bathroom. So these are the different cases. The case 1 was a case of hypoglycemia in a type 1, despite stopping insulin, turned out to be factitious. And case 2 was a long duration of recurrent postprandial hypo, turned out to be a reactive. This was third was a lady with recurrent fasting, which turned out to be a insulinoma. And this was a recent onset, short duration after a drug exposure, which was autoimmune. And the case 5 was the first episode of a severe hypoglycemic seizure, accidental sulfonylurea or intentional sulfonylurea exposure. And case 6 was a hypoglycemia in type 2, which turned out to be factitious. So these are the different patterns you can see. Insulin autoimmune, both are elevated, but the ratio is more than 1. Insulinoma, both are elevated, but the ratio is less than 1. In exogenous, insulin is high, C-peptide is low, ratio is more than 1. Secretagogue, both are elevated, but the ratio is less than 1. The most important clue is from the history. So these are the different treatment modalities, like factitious, counseling, reactive diet modification, ectopic, we need surgical excision. Autoimmune, our patient had a spontaneous remission, sulfonylurea exposure, counseling and other legal issues, and factitious, again counseling. So for in adults, hypoglycemia needs a simple and systematic evaluation. More important should be given to the critical samples measuring insulin, C-peptide, and ketones. Not all hyperinsulinemic hypoglycemia or insulinoma. Consider insulin autoimmune and sulfonylurea exposure, and avoid any unwanted costly investigations and surgical interventions. Thank you very much.
Thank you, Ram, for extensive case-based review on hypoglycemia. I have 2 questions. Is there insulin receptor antibodies is available in India? Insulin receptor antibody assay, one. And second question, in the last case of hypoglycemia, where insulin level was high and C-peptide also was high, and we are suspecting it is insulin induced, is there possibility, is there patient who was taking both insulin and sulfonylurea? So which can explain, in addition to high insulin, that is C-peptide also high.
Yes, so regarding the first one, the anti-insulin antibody, this was actually done in UK. I think this was sent to I don't remember the exact hospital. It was not available in India. Only anti-insulin antibody is available.
Okay.
And even when we sent the reports, he did all the other levels also, insulin, C-peptide, and his first impression was factitious. Although there were almost 6 or 5 endocrinologists who had seen this patient. So he did not agree to any of that, and family had spent lakhs of rupees for that, because they were still thinking that something wrong with this patient. It is possible that he could have taken other sulfonylureas. The only explanation which I found in the JCM guidelines was the only confusing picture in this patient was the high C-peptide. So actually, if you look at the C-peptide was more than 0.6 consistently. Then we looked at the JCM guidelines that cutoff of 0.6 is not applicable in a patient on CKD. So that is the likely, because the C-peptide clearance also depends on the normal renal function. And when we looked at the previous insulin C-peptide, a few months back when his creatine was 1.7, the C-peptide was not that high. So that could be one reason why the C-peptide was high in a patient with CKD.
Right. There is one question in chat box for you, Ram. What is the blood sugar cutoff at which you'll advise for doing insulin and C-peptide level in a patient with clinical symptoms of recurrent hypoglycemia?
Yeah, so normally we take the level as less than 55. So I think you should take the critical sample only when the lab documented value is 55. At this time only you should do the insulin, C-peptide, and other hormones.
Okay. Thank you. Thank you, Dr. Ram, for an excellent talk. So thank you all the speakers in this session. So now we'll move on to the next session.
Okay,
I thank our speakers for the informative session. Now we will move towards our next panel discussion on Cushing syndrome. For the next session, I would like to invite Dr. Adeline Rina for moderating the session. Madam is Associate Professor Endocrinology at Sri Ramchandra Medical College and Research Institute, Chennai, and she has various publications in the national and international journals. Over to you, ma'am.
Thank you for the kind introduction. And at the outset, I would like to thank the Trendo 2020 team for having us here to moderate this panel discussion on Cushing syndrome. I have with me 3 eminent endocrinologists who would be the panelists for this particular session. So first we have none other than Dr. P.G. Sundararaman sir, who is a very renowned senior endocrinologist who works at Apollo Hospitals and Wilroth Hospitals in Chennai. He has decades of experience in endocrinology, and he has been conferred the Best Doctor Award from the prestigious Tamil Nadu Dr. MGR Medical University. And he has delivered multiple orations, including the presidential oration in Trendo previously. He was the president of the Endocrine Society of Tamil Nadu between 2015 and 2016 and has many publications and book chapters to his credit. I also have with me Dr. Varun Kumar, who is the second panelist, who is a consultant endocrinologist at Velamal Medical College and College Hospital and Rio Children's Hospital, Madurai. He is the founder of Ramnad Hormone Center at Ramanathapuram. He has multiple paper and poster awards in various conferences which has been held previously and has got a good amount of publications in national journals. Welcome, Dr. Varun. And I have with me the third panelist, Dr. D.B. Nayak, sir, who is the additional professor and head Department of Endocrinology from JIPMER, Puducherry. He has a very wide area of research, including steroids, cancer-induced diabetes, osteoporosis, and adrenal disorders, and has more than 50 publications in well-reputed journals. Thank you for being here, sir. So without much ado, I think we will go on with the panel discussion. So we will be discussing about 4 cases in whom we had suspected Cushing syndrome, and we will be giving you the clinical, biochemical, and radiological clues as to how you can pick up this Cushing syndrome, which is a relatively rarer one, but not a totally uncommon endocrinological disorder. So to move on with the first case, So it is a 42-year-old gentleman who presented to us with progressive weight gain and facial puffiness for 8 months of duration. He had no history of proximal myopathy, no history of diabetes or hypertension, and he denied using any of the drugs which could be attributed to his weight gain and the current symptoms. On examination, this is how he looked. As you can see, he had a preferential centripetal fat distribution where the fat has been accumulated in his chest and abdomen with relatively thin extremities, what we call as conventional lemon on stick appearance, which is classical of a hypercortisolemic state. And on the other hand, you can also see the puffiness of face with which he has presented. He had a significant buccal pad fat and the preauricular fat deposition, which was also visualized. And you can see the pigmented striae on the lateral side of the abdomen. So on looking at him, we suspected a hypercortisolemic state, and we went ahead and did the biochemical test. So the biochemical test showed that the 8 AM serum cortisol was 2.5 micrograms per deciliter, which was low when you really suspect a clinical hypercortisolemic state. And the paired ACTH for this patient was 14.7, which is again in the lowish range, which is not very commonly seen with Cushing syndrome. So with a low cortisol and a low ACTH, with a normal potassium and a pre-diabetes state, we wanted to rule out exogenous Cushing syndrome, what happens because of the external intake of steroids. It could be in the form of oral medication or a topical application or even injectables, could cause what we call as the hypothalamo-pituitary adrenal axis suppression by reducing or inhibiting the ACTH and thereby causing low cortisol biochemically, yet have a Cushing's-like picture clinically. So on further probing, as we found out that he was on oral methylprednisolone for his joint pain for many, many months now. So many times we often come across these kind of cases, and we are sometimes clueless when patients completely deny the drug history. So sometimes it may not be what has been prescribed by a doctor or what they may have bought from the pharmacy, but many times it could be even the herbal preparations or native medications which could contain steroid-like component contributing to such symptoms. So my first question to Dr. P.G. Sundararaman sir would be, how common, sir, in your decades of endocrine practice, you come across this kind of exogenous Cushing syndrome? Which is more common? Do you think exogenous is more common or endogenous Cushing syndrome?
Thank you, Adeline. The incidence of Cushing's as such, as a whole, is around 2 to 3 per million per year. And you know very well, Cushing syndrome is a general terminology, irrespective of the excess of adrenal steroids, whether it's from the adrenal gland or the pituitary or any other source. But basically, most important reason for Cushing syndrome is exogenous type. Exogenous is the most common condition which results in excessive Cushingoid features. And it's very important. In fact, we had an early lecture by Professor Karim, who told us very succinctly that the dose of prednisolone, which is around 2.5 milligrams, is equal to 20 milligrams, 15, 20 milligrams. So, you know that such a low dose is, which is physiological, which is pharmacological, is a very big problem. Most of the cases uses a very supraphysiological pharmacological dose. And as you have correctly told that most of the times you don't get the allopathic type of medicines that they consume. They consume herbal, homeopathy, Unani, or any other preparations, which is all causing this type of exogenous type of Cushing syndrome. So in our endocrine practice, clinical practice, the most common cause for Cushing syndrome is going to be exogenous type.
Thank you, sir. My next question to Dr. Varun would be, how do we really differentiate the exogenous Cushing's, which is more common in clinical practice, from the slightly uncommon endogenous hypercortisolemic state that could help the clinician to pick up the actual Cushing syndrome?
Good evening, one and all. At the outset, I would like to thank the organizers when you see a patient with exogenous Cushing syndrome, they tend to present with florid protein catabolic features. That is, they tend to have more catabolic features. They tend to be having lesser pigmentation, hyperpigmentation that we expect in a ACTH dependent Cushing syndrome will not be there. Again, because of low ACTH, the patient will not have mineralocorticoid excess phenomenon like hypertension and hypokalemia kind of pictures may not be that much evident. Again, when you look into the hypertension characteristics, they tend to be very much lesser incidence. Particularly, it is reported around 20% in exogenous versus 75% in endogenous. Psychiatric features like depression is more common in patients with exogenous compared to, endogenous compared to patients who are taking tablets of steroids. They tend to be euphoric. So these are common features which we can differentiate between an exogenous and an endogenous hypercortisolemia.
Thank you, Dr. Varun. May I now ask Dr. Nayak sir to tell us about the consequences of using the unprescribed or unmonitored long-term steroid use. Most of times they have the feel-good feeling for which the doctor would have prescribed for a few weeks, but they would be continuing for a long time. So what are the consequences of long-term steroid use, sir?
Thank you, Adeline. As you told that many of the patients have been prescribed for short term, but they continue to take on steroid. That is very common practice in India. If you look at the consequence of long-term use of steroid on without any monitoring, the side effect of these drugs are primarily depends upon types of steroid they are using, whether they are using drugs with having high long half-life, and the route of administration of the steroid, and it also depends upon um, uh, other comorbidity patient have, like a patient is taking bronchial asthma or some other disorder, and which time they are taking the steroid, because those patients taking steroid at night, they probably have more risk for developing the HP axis suppression. That is a very common side effect we see in patient with those are taking steroid. And most of the time, what happen? People don't evaluate this patient for HP axis suppression. They immediately stop this medicine. So sometimes they can land up with a adrenal crisis or even a shock. And other side effects which are very prominent are, as you've seen this clinical picture of this patient, redistribution of body fat is very typical, and increased central obesity, and particularly in female, they definitely will complain the increasing weight gain, and even they can have increased facial hair, development of acne, and particularly in children, short stature because of side effect of the drugs is very common. Other side effect of on monitoring long-term steroid is like osteoporosis is a very asymptomatic disease. Patient can present with fracture, either hip fracture or vertebral fracture. Other side effects are like involvement of eye. They can have subcapsular cataract, development of open angle glaucoma. These are the main major side effects we seen in patient with long-term steroid, and they also can develop hypertension or diabetes. But in this particular case, patient blood sugar are within means just in the impaired glucose range.
So thank you, sir. So as a quick learning point from this case one, which was an exogenous steroid intake causing Cushingoid features, we understood that the exogenous Cushing is more common than the endogenous Cushing, and we will be able to differentiate it clinically based on the absence of pigmentation, absence of the other metabolic abnormalities which are more commonly associated with endogenous Cushing syndrome. And obviously, when we really identify the medication which the patient is already on, you have a clear diagnosis. And of course, biochemistry would help you with a low-ish cortisol and ACTH also. And do remember that the axis suppression depends on the type of steroid used, dose of steroid, and the duration of steroid used. And we also heard about the consequences of this long-term steroid use without monitoring. So we will move on to case number 2, which is a 27-year-old lady who is single. who presented to us with oligomenorrhea, weight gain, increase in facial hair, and acne for the last 6 months. So she was evaluated elsewhere, and ultrasound showed a bilateral polycystic ovaries feature, and she was treated with oral contraceptive pills. She did not have a withdrawal bleed, and hence she was referred to us for further evaluation. So this is the patient which we are looking at. So as you can see, she had gained weight. She is obese. You can notice a lot of pigmentation, hirsutism significantly, a lot of acne eruptions, and even the scalp balding. And she had a neck hump. The most striking thing is the facial fullness and the facial plethora. Though she may be a dark-skinned individual, you could probably appreciate the facial plethora and the fullness or the round face, which was previously called as moon facies. So on a closer look, she also showed a lot of wide purplish thick striae, which was seen in her arms, chest, abdomen, and even thighs. And she also showed some pigmentation on the nail beds, and as you can see, some ecchymotic patches. So though you may have a first look at these kind of patients, getting their previous photographs could really help you. So this was the same patient before she had developed any of the current symptoms. And this is how she turns out to be after developing all these symptoms. So with all clinical suspicion of Cushing syndrome in this particular patient, I would like to ask our panelists, when do we suspect a Cushing syndrome clinically? And what are the subtle features which we can look up? We all know that PCOS is a more commonly encountered clinical condition compared to Cushing syndrome. How do we really suspect Cushing syndrome when patients present with secondary PCO features? Dr. Sundaraman, sir?
Yeah, it's quite interesting that, in fact, in the first case that we have seen, we saw a very low cortisol level, and that is the first and foremost biochemical evidence that you are dealing with a case of exogenous Cushing's. Now, there are conditions which mimic Cushing's, including sometimes the PCOD or stress or any other secondary causes. In fact, first of all, the bedside diagnosis. When do you call as a mooning of face? So whenever you're not able to visualize the pinna of the ear, that is one thing. And scleral edema is a very, very important sign of endogenous Cushing's. And now, in fact, the exogenous Cushing's, normally they have a psychiatric problem, they have increased appetite, they have acne, gastritis, fungal infections are quite common. Usually the classic Cushing's usually insidious in children. In fact, it may be presenting with a stunting of growth, generalized obesity, and virilization in a girl child. Apart from the usual presentation, we must look out for electrolyte disturbances, menstrual dysrhythmicity, especially in the reproductive age group. They have hirsutism. In fact, Cushing syndrome is one of the reasons for a polycystic ovarian disease. It can cause polycystic ovarian disease. But what is very, very important that in a long-standing Cushing's, you've got muscle wasting and weakness. Proximal myopathy is one of the important things. The last thing is going to be bone loss. So these are the important clinical presentation that we'll pick up, that whether you're dealing with a classical Cushing's or it's going to be a pseudo Cushing's. Now, pigmentation is an important feature because pigmentation can occur in a classical Cushing, but when you have a more pigmentation, you must think of hypothalamo-pituitary axis normality like ACTH or ectopic ACTH production. So it is very important that you go into the history, you go into the clinical photographs, as you have correctly pointed out. You must ask for earlier photographs and how they differ. That is very important. And definitely the first clinical examination, history taking, is very important, though laboratory will substantiate your findings. But once again, history and clinical examination is very, very important.
Thank you, sir. Dr. Varun, are there any clinical clues to pick up apart from the list which was clearly explained by Sundaraman sir? Will you be able to tell us if there could be any other signs in terms of the anovulation or the hirsutism which we see in PCOS, whether there could be some difference which we can pick up clinically?
Yes, ma'am. PCOS is very common compared to patients with Cushing's disease, so Cushing syndrome such. So, when the patient, when you get a case of hyperandrogenism, the differentiation between Cushing's and PCOS is much of always a, debacle. PCOS tend to present particularly in a young female in a peripubertal or a peripartum period, and again the hyperandrogenism is going to be very striking with the skin getting thicker and thicker. The insulin resistant markers will be much superior. These are some of the points in favor of PCOS, but when you look into a patient of Cushing syndrome, they will typically the perioral or the mucosal hyperpigmentation is going to be very much a marker. Again, proximal myopathy, it's going to be a double marker for Cushing's. Again, the presence of wild striae is also going to be much more suspicious. The skin is the most important marker. It is going to be thin in a long-standing Cushing syndrome compared to a patient with PCOS who's going to have a thick skin. Thick, hairy skin in PCOS versus a thin, shiny skin in a Cushing syndrome. These are some of the clues for diagnosing or differentiating.
Yeah, just to add on to that, apart from the skin, the hirsutism is very mild or slightly moderate in the PCOS, where you can have an extent of virilization where you can encounter clitoromegaly with severe alopecia or the scalp balding in Cushing syndrome in extreme cases. So moving on to the next question, how do we go ahead when you really suspect a Cushing syndrome clinically? How do we really proceed in evaluating these patients further? Dr. Nayak, sir?
When you are suspect a Cushing, as we have already discussed, there are some discriminating clinical feature which highly suggestive of Cushing. There are certain features, chance of Cushing are less likely. So when you suspect any patient as a Cushing, primary thing to establish whether the patient has hypercortisolism or not. So there are certain investigation which is been cited by the Endocrine Society of Endocrine Society. We usually follow that guidelines for evaluating such kind of patient. Coming to the biochemical investigation, which is recommended by the Endocrine Society, is looking for our 1 milligram dexamethasone suppression test, salivary cortisol, 24-hour urinary cortisol. These are the low dose dexamethasone suppression test. And sometimes they recommend even to do the midnight cortisol, but midnight cortisol is that patient need to be, when you are evaluating a patient, you should look at which investigation will be appropriate. Means in the looking at the patient whether you're able to willing to get admitted, because when you're willing to do midnight cortisol test, patient need to be admitted 24 to 48 hours prior to doing the test. So looking at the feasibility, you can decide which test will be appropriate for the patient. Also, it also depends upon clinical setting, which clinical settings you are evaluating the patient, because one test can do better in, like let's say chronic kidney disease or something. Then in that particular cases, like 1 milligram dexamethasone test may not be appropriate. And during pregnancy, in that setting, maybe urinary cortisol or salivary cortisol will be appropriate. So depends upon the clinical setting you should consider. But as we have seen previously, exogenous Cushing is the more common Cushing. So most of the time you should first and priority should be to rule out the exogenous Cushing. In this, and almost all the patient suspecting Cushing, we should do ATM cortisol to rule out the exogenous Cushing.
Thank you, sir.
And with regard to salivary cortisol, as the most of the these investigations are not available, the primary three tests we commonly do to evaluate the patient for suspected Cushing.
So we had evaluated this patient, as rightly pointed out by Dr. Nayak, sir. We went ahead and did an 8 a.m. serum cortisol, which was high, 22.5 micrograms. We went ahead and did a 1 milligram dex suppression test, which showed an unsuppressed cortisol. Instead of less than 1.8, it was unsuppressed at 3.4. And the low dose dexamethasone suppression test was also unsuppressed at 3.2 micrograms per deciliter. we went ahead and did a 24 hours urinary free cortisol, which was again high at around 312 micrograms. So once you establish a hypercortisolemic state, we want to know the ACTH level in order to determine the source of the cortisol. So we went ahead and did an ACTH, which came as 116 picograms per ml, suggesting that it was a ACTH dependent Cushing syndrome. So because the ACTH dependent Cushing syndrome is expected to have a pituitary lesion, we did the pituitary functions, which showed a lowish FSH and LH, a normal prolactin and thyroid functions, normal blood sugars, and a normal potassium, which is mandatory to be done in all of our Cushing suspected patients. So overall, this particular patient had a hypercortisolemia, definitely an endogenous ACTH dependent hypercortisolemia or Cushing syndrome with a normal other pituitary functions, except for the lowish FSH LH. Unlike the PCOS, where you tend to have a LH which is higher than the FSH. So this can be used also to differentiate Cushing's from PCO. So Dr. Sundaraman sir, how to determine ACTH dependent and ACTH independent Cushing syndrome when we clinically suspect, biochemically prove that the cortisol is high and unsuppressed following dexamethasone? How do we determine the source of the excess cortisol?
It's quite interesting. If you see the case, first of all, as I told you, that first clinical, then only you come to the biochemical part of it. Clinically, you have nicely showed the previous photograph and the present photograph. It showed a difference. And if you closely look at the face, there is a typical mooning of faces along with acne and hirsutism. And later on, you also highlighted the edema of the dorsum of the hand with the pigmentation of the knuckles. So these are all important clinical pointers that lead on whether this patient is having ACTH dependent or ACTH independent. Next, you have done serum cortisol estimation and serum ACTH estimation, and both of them are elevated. And this clues it is going to be an ACTH dependent type of thing. Still, we can assess by doing a dexamethasone suppression test. Now, you have got an overnight dexamethasone suppression test with a single dose, or it is going to be a low dose dexamethasone suppression test, which you have already done. And normally the values must be less than 1.8. But in this case, there is no suppression with a low dose dexamethasone suppression test. So then we proceed with a high dose dexamethasone suppression test, where in cases, if it is going to be an ACTH dependent, you will find a 50% reduction in the levels of the serum cortisol. And then subsequently, if you have accessibility to the CRH, you can do a CRH stimulation test to know whether it is going to be elevated with CRH, because that will give a clue that if it is going to be elevated to the CRH, it is going to be from the pituitary gland. If it is not elevated due to CRH, then it is going to be an ectopic site. So this is how you differentiate between ACTH dependent or ACTH dependent, independent, in a perspective of a general practitioner.
Thank you, sir, for making it very, very simple and easy to understand. Dr. Varun, what is cyclical Cushing's? We've heard about an entity called cyclical Cushing's. Does our patient would fit into this particular category of cyclical Cushing's?
Yes, ma'am. Cyclical, the word implies that is characterized by periods of waxing and waning of symptoms and signs of increased cortisol state. But when you do a dynamic testing, the dynamic testing comes negative. So to define biochemically, we tell that the biochemistry should be positive for at least 3 times, and it should have negativity for two times in over a week's or month's time. Again, this occurs due to the change in pattern of hormonogenesis because of aging of cells in the tumors. So when the patient comes to us with symptoms, we need to screen and with the urinary free cortisol, which is a better indicator, rather than a dynamic testing straight away, and then we need to proceed for further evaluation. So it is very common with tumors in the pituitary than in the ectopic. So still it can be there with it is very common in the endogenous hypercortisolism. So our patient doesn't actually fit in, but still we need to consider when the patient is having a waxing and waning symptoms as such.
Yeah. Thank you so much, Dr. Varun. Dr. Naik, sir, now that we have a clinical suspicion, we have proven biochemically that it is an ACTH-dependent Cushing syndrome. How do we further proceed in this particular patient?
As we know that ACTH dependent Cushing are the most common type of Cushing, and most common source of origin is pituitary. And unless otherwise you have a high index of suspicion that it's probably or clinically fitting into ectopic. First line of investigation, as Dr. Sundaram sir told, we follow the principle of there is total CBI principle: first clinical, then biochemical, then imaging. You should follow this kind protocol rather than directly imaging the pituitary, as we have already done we have seen the clinically and we have done the biochemical investigation. Last line of investigation should be imaging, unless you are thinking otherwise ectopic Cushing or something. So imaging wise, first thing we should do a pituitary imaging with appropriate gadolinium
Contrast, yeah. So this particular patient, we went ahead and did an MRI brain with dynamic contrast, and it showed a pituitary microadenoma. As you can see, a hypointense lesion on the right side of the pituitary gland on the coronal and the sagittal section, suggestive of a pituitary microadenoma, which was measuring 9 into 8 millimeters. Now, to call an adenoma microadenoma, it needs to be less than 10 millimeters, and to call it a macroadenoma, it needs to be more than 10 millimeters. So this particular patient had a microadenoma measuring around 9 millimeters on the right side of the pituitary. So we went ahead and subjected the patient for transnasal stance-sphenoidal excision, and her post-operative day 3 cortisol was very low, which kind of reassured us that we are probably looking at cure for this particular patient. The cortisol was 1.6 micrograms. She was started on oral hydrocortisone to maintain the cortisol axis. Her histopathology came back as pituitary adenoma with IHC being positive for ACTH. And on follow-up, she did really well. We had reassessed her axis and we were able to stop hydrocortisone. She resumed her periods, and this is how the patient looks now. So as you can see, there's a lot of difference in terms of pigmentation. The hirsutism has gone, the acnes have disappeared. Of course, she still has some balding, but there's no active hair loss, and there is some regression of the striae also. So overall, the patient is doing well, and she's one of the luckiest few who is really looking at a Cushing's cure. So a learning point from case number 2 is that Cushing syndrome can mimic PCOS, and you need to pick up the clinical clues of thin skin when compared to a thick skin in PCOS, presence of proximal myopathy, pigmentation, especially as Dr. Sundaraman sir was mentioning on the knuckle pigmentation, the nail pigmentation, ecchymosis, and striae, which could help you to go ahead and do the biochemistry and the radiological examination for patients with suspected Cushing's. Moving on to case number 3, this is a 39-year-old lady who is married with 2 children. She comes to us with amenorrhea for 1 year, with history of depression requiring medications. But when she came to us, she had stopped all the medication for at least 2 to 3 months. She was recently detected to have diabetes and hypertension with no family history of diabetes. And her primary current problem was recurrent gluteal abscess, for which she needed a good glycemic control and fitness for surgery. So with this background of presenting to us with uncontrolled blood sugars, this is how the patient was looking. I'm sure you would be able to relate this patient with our case number 2. You can see the rounded face with the preauricular pad of fat, with facial plethora, hirsutism, some pigmentation, and the disproportionately thin extremities in comparison to her centripetal obesity. So in this particular patient, we had encountered diabetes and hypertension. Both were newly detected during the last 8 months of symptoms by the patient. So Sundaraman sir, how common is it to have secondary diabetes and hypertension in patients with Cushing syndrome?
Yeah, it's interesting to note that secondary diabetes is one of the important causes which is causing a lot of morbidity in Cushing's. And about more than 50% of patients with Cushing's will have varying degree of altered glucose metabolism. In fact, they have postprandial hyperglycemia. If you do a fasting, initially in the initial period of their clinical picture presentation, they won't have a fasting hyperglycemia, but they will have a postprandial hyperglycemia. It upregulates the key gluconeogenic enzymes. It has insulin resistance and it increases hepatic glucose output. And all this contributes to a elevated level of glucose level. That is why the patient is having a repeated gluteal abscess. And if you're going to do only a fasting blood glucose, then we'll miss a lot of times in the initial period. So that is important that regarding the diabetes. Hypertension is also an important cause, and it causes an important comorbidity. It causes because of the stimulation of the mineralocorticoid and the glucocorticoid receptors. There is a sleep apnea in most of these conditions. They have hypertension coexisting, and there is overexpression of the renin-angiotensin system. And all these contributes to the elevation of the systolic and diastolic blood pressure. So put together, they have an increased incidence of diabetes and hypertension in the Cushing syndrome.
Thank you, sir. So this particular patient had psychiatric disturbances in form of depression. So Dr. Varun, do you think that it is just the cause of this hypercortisolemia, or could it be an effect of the hypercortisolemia? And if you could tell us what we mean by saying pseudo-Cushing's.
Yes, ma'am. The psychiatric disturbances occurs as one of the most common comorbid condition in a patient with Cushing's. It can be varied between major depression to lesser extent with mania or anxiety. So the basic psychopathology is the increased the sympathetic output from the brain. So the initial stimulation occurs from the brain, but once it is chronically stimulated because of the Cushing's hypercortisolemic state, it goes into a neurodegeneration. So the presentation is variable, but the most common the manifestation is major depression in most of the patients, amounting around 80 to 90% in most of the studies. When they look into the therapy part, the drugs for hypercortisolemia actually reduce the symptoms of major depression rather than antidepressant agents. Again, once the surgery is causing remission of hypercortisolemia, there was up to 50 to 60% remission of most of these symptoms. But still, when they looked into a long-term studies, and the patient had minimal disturbances in the form of cognitive disturbance or minimal, depression was still persisting in most of the patients. So the age of presentation and the treatment, early treatment is the key for important remission as well. Coming to the second part, coming to the pseudo-Cushing's part, pseudo-Cushing's is nothing but it's a reversible part of disorder where the patient has signs and symptoms of hypercortisolism, but when you do a dynamic testing or testing for hypercortisolism, it is going to be absolutely normal or mildly elevated. So conditions like obesity, depression, alcoholism are the most common disorders where they can present. Again, PCOS can again present with pseudo-Cushing syndrome. So the main pathophysiology is the chronic stress. So chronic excess hypercortisolism stimulation is the main culprit. So once we treat the underlying disorder, they tend to remit. That's a main clue for us to diagnose. The usual the dexamethasone suppression usually tend to be falsely positive, so it is always better to go for combined dexamethasone CRH suppression. That is going to be a better gold standard. So midnight cortisol is again going to be a better screening test for these patients as such.
Thank you, Dr. Varun. So, Dr. Naik, sir, can you tell us the other comorbidities and complications which a patient with Cushing's syndrome can develop if we let them undiagnosed or maybe untreated?
As we seen discussed in the previously, the long-term side effect of on monitoring not steroid intake, there are several side effects, and in this particular case, as we have seen, the metabolic side effects like secondary diabetes and even hypertension are very common, and even the psychiatric disorder. So there are other side effect or complication can be occur if a patient is left untreated. like there can be a chance of mortality because of secondary infection in such kind of patient, and as you seen this patient having recurrent infection because of decreased immunity, and this patient are very more prone for the infection, and if untreated there is also chance of increase atherosclerotic cardiovascular disease in the form of like myocardial infarction. And interestingly, these patients, even they develop myocardial infarction, sometimes the coronaries can be found to be normal. Sometimes these patients land up with a cardiology department and they found the coronaries is normal. They find probably that patient not having. So in this setting, in patient, there are other complications they can develop, like even stroke and transient ischemic attacks are very common. There was a discussion saying that this kind of patient have decreased cognition. There are studies recently looking at volume of the brain in the NRM spectrometry and seeing that these patients have cortical atrophy, decreased cognitions are very common. Other problems they can happen that as we have discussed earlier, the osteoporosis and osteoporotic fractures are very common. And if somebody sustained a hip fracture, then definitely there is an increased morbidity and mortality can be double in such kind of um, patient. There are other side effects we see in like ophthalmological side effect I already told, and other important side effect can have. Like you have not discussed regarding metabolic. Another important metabolic side effect is dyslipidemia that can happen in patient on Cushing syndrome or those are on exogenous steroid. Particularly patient with the exogenous steroid, they also can develop avascular necrosis of the head of the femur. But that it's not very common with endogenous Cushing, but it can common with the exogenous Cushing.
Thank you, sir. So we started her on basal bolus insulin, giving her a good glycemic control, and she underwent the procedure. And the most important thing is we need to achieve good glycemic control before we really evaluate these patients with suspected Cushing syndrome in the background of infection. So after controlling her infection, we did the investigations, which showed again a high 8 AM cortisol, unsuppressed 1 milligram, and a low dose dexamethasone suppression test, and almost 3 times elevated 24 hours urinary free cortisol with a high ACTH, again pointing towards a pituitary and ACTH dependent Cushing syndrome. And the other pituitary functions showed suppressed FSH, LH, normal prolactin, and a low free T4, suggesting that it's not just hypercortisolemia, but there is some pituitary dysfunction with high blood sugar and normal potassium. So we also went ahead and did an MRI brain, which unfortunately in this particular patient picked up a pituitary macroadenoma. As you can see, more than 10 mm lesion on the right side, lifting up the optic chiasm, causing vision involvement also in this particular patient. So Dr. Sundaraman sir, what are the remission rates in the microadenoma? We saw the patient case number 2 with microadenoma having a cure, and what would be the cure in these kind of patients with macroadenoma?
Okay, surgery-related hypopituitarism is more common, and in fact, the overall remission in Cushing's adenoma is around 72.7%, and majority of recurrence occurred between 5 to 10 years of life. In Cushing's disease, age, gender, tumor size, macroscopic tumor invasion were not prognostic factors. And immediate postoperative serum cortisol is very useful to know whether there is a remission or not. And they have a very good chance compared to the other tumors of the pituitary, Cushing's. If you're able to properly identify, give it to a proper surgeon, the remission rate is very good, especially. But also you must look out for more of hypopituitarism in them. And one of the important tests is the immediate post-operative serum cortisol. If it is dipping down, it is excellent.
Thank you, sir. Dr. Varun, can you tell us quickly if diabetes and hypertension in these kind of patients remit or go in for a remission once we really cure the Cushing syndrome?
Yes, ma'am. In the incidence of glucose intolerance is noted around 35% in most of the studies, and the diabetes is around 10 to 15%. So when the patient is having a family history, and if the patient is having over diabetes, the moment the hypercortisolism is controlled, their sugar control becomes better. even patients are reported to have a remission of around 20 to 30% in studies. Again, when the patient is having a glucose intolerant state with just meager rise of sugars, they tend to be having a complete remission of the intolerant state together, following the remission of in the hypercortisolism state. So it depends upon the stage of the disease and family history of diabetes. Coming to hypertension, the hypertension is again, it's going to be variable in the remission, but most of the patients, they tend to remit with the control of hypercortisolism as such.
Yeah, thank you, Dr. Varun. So the other question is the long-term consequence of Cushing syndrome, which has been in detail explained by Dr. Naik, sir. So I am skipping in want of time. So the quick takeaway point from case number 3 is patients with Cushing's can present to you with secondary diabetes and hypertension with lot of metabolic abnormalities and very significant infection with sepsis. So do keep in mind to control this infection before we really evaluate these patients. Moving on to our last case, which is case number 4, a 36-year-old lady, bilateral lower limb weakness, difficulty in walking for the last 1 to 2 months, a very short history, and she became quickly bedbound in the next 2 weeks. And on probing, she said she also had amenorrhea for 3 months. She was evaluated elsewhere for the quadriparesis, and she was found to have hypokalemia, on which evaluation was done, which showed an enlarged, bilaterally enlarged adrenal gland in the CT abdomen. So this is the patient, as you can see, with fullness, again, the rounded facies with pre-auricular pad of head, acanthosis. And as you can see that the pigmentation component is not much severe in this particular patient because of the simple reason that it was a very short history and a rapidly progressing Cushing syndrome. So she has not yet developed the pigmentation. This was the patient's old picture for you to compare the Cushing feature in this present scenario. So, Dr. Sundaraman sir, what are the peculiar features in this particular case? Why would this case be different from the case number 2 and case number 3, which we had already discussed?
So whenever you have a very short duration history of the appearance of Cushingoid features, if you see compared with the picture, you find a Cushingoid feature. And from the history, you have told that there is evidences of weakness or wasting. And another important problem with these people, they have persistent hypokalemia and they go into metabolic alkalosis, and which is due to the proximal. They also have proximal muscle weakness. They have edema, hypertension. And whenever you find the short duration of history with evidences of weakness because of hypokalemia or any metabolic insult, we must think of some ectopic source. And you don't have the florid pictures of Cushingoid to start because it's a short duration. It must be a tumorous type, which is going to be a real concern for us to detect it earlier and treat it earlier.
Thank you, sir. Dr. Varun, in this particular patient, we are talking or thinking about an ectopic source of ACTH causing the Cushing syndrome with respect to the short history and the rapid progression with not much significant features of Cushing's in this particular patient. What are the frequent ectopic sites one could think of when you are really suspecting ectopic source of ACTH?
Nice one. The ectopic ACTH secreting tumors, with the advancement in the imaging techniques like functional imaging, the foregut, that is the larynx, to the thymus, lungs, stomach, or duodenum are the most common preferred areas of the sources. The most common predominantly will be in the bronchi with 20 to 40% of the cases. When you take the chest imaging, the incidence is going to be around 40 to 60% of the cases will be located in the chest. The remaining will be in the abdomen. The more rare sites like the small gut, breast or ovary or prostate are going to be most rarest of the locations. These are all ectopic ACTH secreting. Still, there is an entity of ectopic CRH secreting. They are going to be most common in the abdomen, particularly the pancreatic, or the sites of adrenal are the most common sites for an ectopic CRH as well.
Yeah, thank you, Dr. Varun. Dr. Naik sir, how different is this case? We talked about the short duration and the presentation, and what can we expect in the labs when we really do the test for this patient, which could be different from case number 2 and case number 3?
As we seen, there is a very short history, and where the clinical features are more pointing towards ectopic Cushing. So laboratory-wise, as Sundaram sir told, hypokalemia is very profound in such patient. Coming to the hormonal evaluation, you can get a very high level of ACTH and high level of cortisol. You can get in such kind of patient. So.
Yeah. So this was the labs of this particular patient, as rightly pointed out by Dr. Naik sir and preluded by Dr. Sandaraman sir. The cortisol was very high in this patient with unsuppressed 1 milligram dex suppression and LDDST, very high values of 24 hours urinary free cortisol and a very high value of ACTH. Now the value, the higher the value, the more likely it could be ectopic ACTH producing tumor. And because of high ACTH, we also evaluated the pituitary functions, which showed a lowish FSH-LH, a normal prolactin, normal thyroid functions, pre-diabetes, and as rightly pointed out by Dr. Nair said, we could see a very severe hypokalemia and a significant alkalosis in her blood picture. So we went ahead and did an MRI brain for this particular patient who showed a normal pituitary. There were no lesions in MRI, despite looking for a very small lesion in a very thin cut and dynamic contrast. So we went ahead and did a gallium dotonox scan, which is a functional scan to pick up tumors like Cushing syndrome, which express the somatostatin receptors, and there was no uptake anywhere else in the body, suggesting that it is not a localizable ectopic ACTH producing tumor. So, Dr. Sundaraman sir, how do we manage these kind of patients with an ectopic ACTH Cushing syndrome? We know that it's an ectopic ACTH producing tumor, but we are not able to localize. So, how do we go about managing these patients? What are the options?
Okay, the treatment is based on two objectives. What we're going to. One is a controlling of the endocrine manifestations. Number two, managing the underlying tumor. So these are the two important things. Now, if you see in this clinical case, you have shown a very fast growing clinical symptomatology. And there is evidences of hypokalemia and alkalosis. And definitely there is a high levels of cortisol and ACTH with definitely the laboratory shows that it is a clear case of Cushing's. Now, whenever you have done the imaging study and you have not found, and it's quite frustrating in some events where you don't find any other cases. If you find any clinical clue, definitely you go for surgeries. Otherwise, you go for the treatment based on these objectives. And whether initially a drug therapy or finally, if you don't have any success, you go for adenectomy. So it depends upon what drugs. I don't know whether I can discuss about the drugs, but whether any other speakers, but normally we have various types of drugs like ketoconazole, aminoglutathione, etomide, metidapone, and somatostatin analogs, or mitotane, which is going to be adrenalytic, or it is going to be some targeted therapies like retinoic acid or propranolol, leuprolol, some of the receptors which is going to be targeted, and that can be done.
Thank you, sir. Dr. Varun, can you quickly tell us the other options of to localize the ectopic Cushing syndrome? Are there any other options which could be done in this patient to really localize the ectopic Cushing?
So this patient underwent imaging of the pituitary, and the functional imaging was done with an gallium imaging. The other options in the functional imaging still we can try with an FDG PET, where the this functional imaging depends upon the phenotype of the tumor. If the tumor is well defined, and if it is having more receptor for an SSTR, then we do go for an octoscan or a gallium dotonac. If the tumor is going to be very much aggressive with more of like a carcinomatous feature, then the FDG PET, that is the glucose PET will be better for picking up the tumors, which is going to be occult. Still, if you are in doubt regarding the tumor, we can still go ahead with the bilateral inferior petrous sinus sampling, where we can give CRH or desmopressin to look for the change in the ACTH and the levels to the peripheries. The last but not least, we can image with the some of the pheochromocytomas are going to be functionally secreting both catecholamines as well as the cortisol. So the MIBG scintigraphy is also going to be useful in such kind of patients.
Thank you, Dr.
Thank
Varun. Dr. Naik sir, can you quickly tell us the name of the drugs which are available now to treat Cushing syndrome? A few has been listed by Dr. Sundaraman sir. If you could tell us, yeah.
There are newer drugs, but it's not available in Indian market, like osiligdotrat and levokitoconazole. There are other drugs which are it is primarily in the preliminary studies like retinoic acid. All these drugs are, but drugs like depends upon which clinical condition you are treating, whether you are treating the adrenal Cushing or ectopic Cushing. Particularly if you are a pituitary Cushing related, you may think of giving pasireotide or cabergoline, particularly those fail to go and develop remission following surgery.
Thank you, sir. So this particular patient, since we were not able to localize,
and a patient those are having like a pituitary carcinoma, I mean, say a very invasive temozolomide may help in such kind of patient.
Yeah, thank you, sir. So in this particular patient, we subjected the patient for bilateral laparoscopic adrenalectomy to remove the target organ because we were not able to localize the ectopic source. She was started on both hydrocortisone and fludrocortisone replacement with stress dosing of steroids. Fortunately, her potassium normalized, she improved, and this is how she looked after 2 weeks after post-operative period. She was sitting up, her mobility improved, she was feeling well, and 6 weeks later, she became like this, and this is because of the high ACTH, which had started to show up in terms of pigmentation, as you can see, but she's still doing well. There's no hypokalemia. She's overall doing well, and she's yet to come for follow-up for us to really go ahead and re-evaluate for the ectopic source. So the learning point from this particular case number 4, which is the last case, is that not all ACTH-dependent Cushing syndrome have a pituitary problem. There could be ectopic sources, which is more commonly associated with a short duration of symptoms, rapid progression, severe hypokalemia, alkalosis, and many times you may lose the patient unless you really act early. So thank you very much to all the panelists for taking us through all these 4 cases, and thank you very much for your patient listening.
Thank you.
Any questions from the audience?
Can you ask some of the chart box? Can you look at the chart box, Adeline?
Yes, sir. So Dr. Amit has asked how to differentiate pseudo Cushing from true Cushing's, because ONDST or LDDST sometimes become positive in the former. Dr. Varun, would you like to answer?
Yes, ma'am. So the clinical clues will be like we are suspecting the secondary disorders where we don't have a florid Cushingoid features, Cushing's features. If you tend to have features of mineralocorticoid excess, we tend to look for it. Second, those are indirect parameters. When the patient is having pseudo Cushing's, the 2 milligram dexamethasone suppression is of better use than a low dose use, low dose suppression. Third, the patients with true Cushing's, usually the ACTH is going to be very much higher, and imaging is going to be of much more use directly rather than going for a pseudo Cushing's evaluation. So the suspicion is the first clue. Second is the right choice of the testing. Routine testing will miss. Will make pseudo false positive in this pseudo Cushing state. So testing depends upon the overall phenotype of the patient.
Thank you, Dr. Varun. Dr. Naik, sir, can you tell us the mechanism of hypokalemia in patients with ectopic Cushing. Dr. Amit wants to know what is the mechanism as to why hypokalemia happens in ectopic Cushing's. Dr. Naik, sir?
As you know that when you have cortisol excess, cortisol is actually metabolized into inactive product by the 11 beta beta HSD. But when there is a excess of cortisol, it can override the action of 11 beta HSD, and it can act on the mineralocorticoid receptors, and it can induce hypokalemia. That is the primary mechanism and for developing hypokalemia.
Thank you, sir. There's one more question from Dr. Palani Chami. Dr. Sundaraman, sir, would you like to answer that? He wants to know whether topical steroids or inhalational steroids can cause Cushing's features or probably Cushingoid features.
Yeah, it's quite interesting to note that the endogenous steroids, that is steroids produced by the adrenal endogenously. Now, how is it different? Because the endogenous secretion can bind with the proteins or other binding proteins. But in these pharmacological, they do not bind. So they are available in the free form, the maximum amount. Now, each steroid is dependent upon their pharmacokinetics, their receptor orientation, and also the intracellular mechanisms. And normally, locally delivered steroids, like a topical application, or it is going to be intraocular or intraarticular, it does not cause much of suppression as we give orally or intravenously. Now, the dose depends upon an individual. If you give a supraphysiological dose, even for a period of week, it causes suppression. But normally, if you take the usual pharmacological dose, if you give for more than 2 weeks, then it also causes HPA axis suppression.
Thank you, sir. If there are no more questions, I hand over the session to the organizers for the next session.
Good evening, doctors. We are expecting our international speaker is to join. So he's received the link. We confirmed with the email. We'll wait for 2 more minutes. I think he'll join because he confirmed that he's received the link. We are not able to reach him on the mobile. We will wait for 2 more minutes. So meanwhile, I would like to announce that the ESTN members have got a general body meeting. I'm audible, madam?
Yeah, you're audible.
Yes, sir.
So ESTN members have got a general body meeting starting at 9 p.m., 9 to 10. So that's not on this platform. That is on a different private virtual platform. Dr. Muthukumaran Jaipal, Secretary of Endocrine Society of Tamil Nadu, has sent the Zoom link on your email ID, which you will have. So that general body meeting starts at 9 p.m. and will end at 10 o'clock. So tonight. Okay, so that I want to say it's not on this platform. It's on a different platform. The Zoom link will be in your email ID. It will not be through this platform halls. So tomorrow we are having 2 important sessions. Hall A will have a Gynae Endocrine Symposium, and Hall B we have interesting bone sessions, and we have Electrolyte Symposium, and then we have Adolescent Endocrinology Symposium. So I invite you all to join us tomorrow for the sessions. Tomorrow we have sessions only till 2 p.m. 1 o'clock in the afternoon. So 9 to 1 we have. By 1 o'clock, by lunchtime, we wind up the sessions. So I hope all of you had time to visit the e-poster sessions. The posters are displayed virtually. Today we had good oral presentations. We had 20 sessions, 20 oral presentations, and tomorrow we'll announce the results of the oral presentations in the valedictory function at 1 p.m. So the international speaker is Professor William Eng. He's supposed to talk on the topic of practical approach to the patient with adrenal incidentuloma. So we are just trying to contact him. So meanwhile, I welcome Dr. Uma Devi, who is a consultant endocrine surgeon from Chennai, to join us for this session. We can start a discussion. Dr. Sriram was supposed to join for the session as chairperson, but he's not able to join, so I will be chairing the session. My name is Dr. Vijay Bhaskar Reddy. I'm organizing secretary for Trendo 2020. My core chairperson is Dr. Uma Devi. She is consultant endocrine surgeon from Chennai. So I request we'll have a small panel discussion till our international speaker joins. So I request Dr. Satish Kumar, additional professor of endocrinology, JIPMER, to join us for this panel discussion. And Dr. Felix Jabba Singh from CMC Vellore kindly join us for this panel discussion. So I would start off with a case scenario. A patient, we know that adrenal incidentalomas by definition are incidental adrenal lesions detected when imaging is done for some other cause. That is the meaning of adrenal incidentoloma. I will start off with a case scenario. I will the case a 40-year-old male patient coming with abdominal pain undergoes a CT scan of the abdomen for evaluation of abdominal pain. He was found to have a 1.5 centimeter small adrenal lesion. So Dr. Uma Devi, so this is done incidentally for abdominal pain, and adrenal showed a 1.5 centimeter lesion. So how would you proceed with such a case in your practice? So the GP or the gastroenterologist will immediately say that this case has got a small adrenal lesion. So you go and meet the endocrine surgeon or endocrinologist. So how would you evaluate this case?
So the patient, when this patient comes, we have to take a good history of the patient. We have to ask her the history, and if she's symptomatic. So even an incidentuloma, the patient might have a few symptoms, which will point towards a diagnosis for us. So this after history, I will like to see if she has any of the features of adrenal tumors like Cushing's, or if she's a hypertensive, I will ask for a FEO. So I will try to rule out everything. Even if she's asymptomatic, I will like to rule out a Cushing's or a pheocytoma. And if she's a hypertensive, I will try to rule out an allergen also.
Dr. Felix Jabba Singh, what is your protocol for such a case in CMC Vellore?
Yeah, definitely the history is foremost important, because today morning also I remember seeing one patient where she actually come with the history of abdomen pain, wherein the patient was done a CT scan because of the persistent abdomen pain, and they found an 1.8 centimeter lesion in the right adrenal region. And so definitely it is very important that the clinical examination was very important, because this patient had a subtle Cushingoid habitus, and but though that was not a classical discriminative features, so it helped in actually getting a cortisol done, and also serum electrolytes, and if there is and DHEA testosterone levels, and an overnight dexamethasone suppression test, because subclinical Cushing's is very evident in a lot of patients with adrenal incidentalomas. And also one should remember that 24-hour metanephrine also has to be done in most of the patients, because there are quite a number of patients with adrenal incidentuloma, even Italian with series which has shown quite a bit of patients with subclinical Cushing. So in our protocol, we usually do DHAs, testosterone, 24-hour metanephrine, cortisol, and also overnight dexamethasone suppression, and further proceed. In subtle patients, we also do an aldosterone and renin also if the potassium is on the lower side.
Thank you, Dr. Felix. So I think so we have to start with the history and examination, and imaging characteristics also help us in deciding the condition, and then we go for a hormonal workup, and we decide based on that. So Dr. Satish, what type of lesions would you like to observe, and what type of lesions would you directly refer for surgery?
This is for Cushing's. Okay, adrenal lesions.
Lesions.
Adrenal.
Yes.
Okay. What type of lesions would you? So, anything with symptomatic Cushing, symptomatic presentation of aldosterone axis. For example, presentation of with a hypertension with a metabolic alkalosis. You have a classic presentation of hyperaldosteronism as a Conn's syndrome. So this is a case of functional presentation of classical hyperaldosteronism. This has to be taken up for surgery. So and similarly, the one presenting as a functional hypercortisolism as adrenal Cushing, this has to be taken up for definitely has to go for surgery. So others will have to take it up depending upon the radiological characteristics and the size and the symptomatic presentation.
Thank you, Dr. Satish. Dr. Felix Jabbar Singh, you told that you will do a aldosterone evaluation and in such adrenal incidentulomas. So my question is, what precautions do you take while assessing the aldosterone and renin activity? What is the current recommendation of how to stop the antihypertensives, or what precautions would you take while doing aldosterone assays?
Yeah, it's very important to know the medication which has been associated, which the patient is currently on. And also it is important to know the serum electrolytes, wherein the potassium, if it is low, it will be good to correct. But however, there are evidence to suggest that it is an autonomous gland, and it's still the renin can be suppressed and the aldosterone can be high. But the Endocrine Society guidelines mentioned to correct the potassium. And secondly, in terms of the drug, other than aldosterone antagonist, most of the drugs, though have an effect on the renin-aldosterone axis, by and large, because of the autonomous nature of the gland, which is producing the, I would say, the adenoma, it generally will not cause much effect on the renin and aldosterone levels in terms of an adenoma or hyperplasia. But if it is a spiral, if the patient is on spironolactone, we may need to tend to stop at least for 3 weeks before having this effect wean on from the blood.
Madam Dr. Uma Devi, when would you suspect adrenal carcinoma in a patient coming for an evaluation of adrenal incidentaloma? What warning signs do you get to suspect adrenal carcinoma? I think Sarah has joined. Sarah has joined.
We will go to the session.
Yes.
I would like to thank our speakers for the last discussion. We now proceed to our next session on approach to adrenal incidentaloma. I would like to invite the moderators for this session, Dr. Vijay Bhaskar Reddy sir and Dr. Uma Devi ma'am. So
I think we are already introduced, madam. We can go ahead.
Yeah, we can proceed further, sir.
Yes. So I welcome Professor William Yang, who has joined us from USA. He's a professor of medicine at Mayo Clinic College of Medicine, and he's Tyson Family Endocrinology Clinical Professor from Mayo Clinic, Rochester. So he is the authority on adrenal incidentoloma. I would not waste any further time. I invite sir to start his talk on a practical approach to the adrenal incidentoloma. Over to you, sir.
Great. Thank you very much for that introduction. It's an honor to be invited to participate in your meeting this year. I've been asked to discuss adrenal incidentalomas, one of my favorite topics. With regard to this presentation, no relevant financial relationships to disclose, no off-label drug usage will be discussed. So we all have to have the same understanding of what we're talking about in this presentation. Adrenal incidentaloma is an adrenal mass discovered serendipitously by radiologic examination. In other words, the scan was not performed because we suspected an adrenal gland problem. And based on a good interview and physical exam, the patient should have absence of symptoms or clinical findings suggestive of adrenal disease. And it should be a significant size, more than 1 centimeter in diameter, leaving no question that it really is truly a mass. Now, one of the most common questions I get after this presentation is, well, what if the adrenal mass is 9 millimeters? Well, the point here is it has to be an adrenal mass. And if it's 9 millimeters, 8 millimeters, 7 millimeters, it's clearly an adrenal mass. Fantastic. It's an adrenal incidentoloma. So every cutoff I share with you today are guidance. There's nothing that's absolute in the field of adrenal disease. So here's a CT scan of a patient with a left adrenal gland incidentoloma. My goal of this short presentation is by the end, you all have a good understanding of knowing exactly what to do with this patient and this adrenal mass. We need to recognize that most adrenal incidentalomas are non-functioning cortical adenomas. Here's a summary of 9 studies, 1,800 patients with adrenal incidentalomas. 3% were malignant, 97% were benign. Those were malignant, 2% adrenal cancer, 1% metastatic disease to the adrenal. Those that were benign, 90% were non-functioning. 6% had subclinical glucocorticoid secretory autonomy, subclinical Cushing's, 3% pheochromocytoma, and 1% primary aldosteronism. Even though only 3% are malignant, it's what our patients are concerned about. It's what, to be honest, we're concerned about as the caregiver. And the key here is imaging phenotype. So I'm going to spend a little time on that. We need to recognize that the development of adrenal cortical nodules is in part a function of age. So this is just a summary of 5 autopsy studies done in the 1940s, 50s, and 60s. And we're looking at the prevalence of an adrenal mass at the time of death. And these are individuals who had no known history of adrenal disorder. So you can see up till age 30, the prevalence of adrenal nodule is very rare. But then with every decade, it increases. So by the time someone is in their 70s, the prevalence is 7%. And we're replicating these autopsy studies with our CT scans and our MRI scans. So the diagnostic strategy with regard to the patient with adrenal incidentoloma is to characterize the adrenal mass with regard to functional status and malignant potential. Functional status with a good history and physical exam focused on signs and symptoms of adrenal disease, and hormonal assessment, which we'll walk through step by step in a minute. Malignant potential, imaging phenotype is the key, and a secondary factor is the size of the adrenal mass. So let's first talk about functional status. And as we do this, we'll build a diagnostic and treatment algorithm. So we start with incidentally discovered adrenal mass, hormonal testing, DHEA sulfate. So men and women make DHEA. It's under the control of ACTH from the pituitary. If a patient has an adrenal tumor autonomously making cortisol, it will suppress ACTH production and DHA sulfate levels will drop. DHA sulfate has a 16-hour half-life. So it's like my adrenal glycosylated hemoglobin, whereas ACTH is fluctuating very rapidly and is not very reliable. So ACTH is not like TSH in the diagnosis of hyperthyroidism. So I use DHA sulfate. If DHA sulfate is low, it suggests chronic suppression of ACTH. We also use the overnight dexamethasone suppression test, 1 milligram dexamethasone, 11 p.m., measured cortisol next morning at 8 a.m. If the adrenal mass is lipid poor, and by that I mean the unenhanced CT attenuation is greater than 10 Hounsfield units, we should screen for pheochromocytoma. That can be with a 24-hour urine for fractionated metanephrin and catecholamines or plasma fractionated metanephrin. If the patient's hypertensive or hypokalemic, we measure aldosterone and renin. If case detection testing is positive, confirmatory testing is performed. If that's positive, we consider surgery. Whereas if confirmatory testing is negative, case detection testing negative, it's all about imaging phenotype. If the imaging phenotype is benign, and by that I mean the unenhanced CT attenuation is low, less than 10 Hounsfield units, telling us it's a lipid-rich adrenal mass. And secondarily, if it has fast contrast washout, then we consider a repeat image at least once, typically a year later. I personally repeat screening for subclinical glucocorticoid secretory autonomy annually for 4 years. The risk of this developing over time is low, but it's a real risk. And you can consider surgery if you're dealing with a large adrenal mass, and we'll come back to that. Whereas if the imaging phenotype is suspicious, and by that I mean the unenhanced CT attenuation is high, greater than 20 Hounsfield units, so it's a lipid-poor adrenal mass. And secondarily, if contrast washout is slow, then we would consider a biopsy if we're worried about infection or metastatic disease. We would consider surgery if the patient's physically fit and if you have an expert adrenal surgeon, or close follow-up with a repeat scan in 2 to 3 months. So imaging phenotype, just looking at a simple measurement of CT attenuation on the unenhanced CT scan. The lower the CT attenuation, the more lipid, the more likely it's a benign adrenal mass. The higher the unenhanced CT attenuation, the less lipid, more likely adrenal cortical carcinoma, ACC, metastatic disease, pheochromocytoma,